Hello, my name is Torbjörn Holm. I'm Associate Professor of Surgery at the Karolinska Institute and Karolinska University Hospital in Stockholm. I'm going to present a case of APE resection to you. This patient had a locally recurrent rectal cancer, which was advanced, and therefore we had to do an extended operation on the patient's right side. We did on the right side an Ischioanal APE, while on the left side we could do a standard extralevator APE. I think we could start the movie now. Here you can see that we have marked the incision line, and here's the tip of the coccyx, and up there is the sacrum. The tumor is located on the patient's right side, close to the top of the levator. We incise in the skin around the anus, but we do not have to make a large incision in the skin. We can keep it quite small. And then, with diathermy, we dissect in the subcutaneous fat around the anus and a bit up on the sacrum, because we have to take off a bit of the sacrum in this patient. The dissection is continued in the subcutaneous fat all around the anus, and once we have entered this plane, it's important to identify the subcutaneous portion of the external sphincter. You see, we follow the external sphincter along the ischioanal fat and the ischioanal fossa, and this is on the patient's left side. As you can see here, the levator muscle is going to the lateral of the coccyx and under or in front of the coccyx. Therefore, we remove the coccyx in these patients. On the left side, we have mobilized the levator muscle almost up to the pelvic sidewall and the obturator muscle, and we can stop the dissection at this point. However, on the right side, the tumor is advanced and we have to remove the ischioanal fat, and therefore we aim for the tuber ossis ischii on the patient's right side. As you can see, we remove all the fat in the ischioanal fossa, and we aim to find the obturator internus muscle on the patient's right pelvic sidewall. Here you can see that we follow the obturator externus muscle, and we try to mobilize the ischioanal fat from this muscle. There is actually a plane between the ischioanal fat and the obturator internus muscle all the way up to the junction between the levator muscle. And by doing the dissection in this correct, well-defined anatomical plane, we can remove all the fat in the ischioanal fossa. Once we have mobilized around the circumference of the levator muscle, and in this case also the ischioanal fat, we should enter the pelvis. Normally, we enter the pelvis between the coccyx and the sacrum. But in this case, we have to enter the pelvis a little bit higher up, and we have to take a piece of the sacrum with the specimen to be able to take out the complete levator, because the tumor is located on the patient's right side on top of the levator. You can see that we have now entered the pelvis, and we are dissecting the last part of the ischioanal fossa on the right side. We have here opened the Alcock's channel, and we divide the pudendal vessels. And here we mobilize the levator from the obturator internus muscle proximal and close to the sacrum. After we have defined the line of transection of the sacrum, we out the swab that we have put down in the pelvis from the abdominal part of the operation. And here you can see the normal dissection of the sacrum and coccyx, but in this case we have to enter higher because the tumor is located there. So we will take off the S5 vertebra from the sacrum to be absolutely sure that we have a good margin to the tumor. This is a more extensive procedure, of course, than the normal extralevator APR, because we take a piece of the sacrum and we take more laterally on the right side than we normally do. On the left side, we have almost finished the dissection. And here you can see the levator insertion to the obturator internus muscle. It's important to stretch the tissues, and therefore we press downwards to stretch the levator muscle and to visualize the insertion of the levator muscle to the pelvic sidewall. Here sometimes you can have bleedings if you come too much lateral, because if you go very close to the obturator muscle, you have the internal iliac vessels, and you must take care and be aware that you can have a bleeding here. But of course you can stop that with a ligature. Now we dissect and divide the most proximal part of the levator muscle, and also the ligament that is attached here. Once we have mobilized the sacrum and the ligament attachment, we can start to divide the levators very, very close to the pelvic sidewall and the obturator muscle. And again, you have to take care not to have big bleedings here. So now you can see the valdae fascia in front of the sacrum, and you can also see a small drain that we have put from the abdomen. Here is the plexus, the neurovascular bundle. On the patient's right side, we still have to divide a little bit more of the levator muscle before we can see the neurovascular bundle. We have to take care not to come too close to the tumor, because the tumor is very close to this area. And therefore it's very important to have a good stretch and a very good view of what you are doing. Once we have mobilized the specimen around the pelvic sidewall and from the sacrum, we take out the specimen to have a better view of the anterior aspect. You can also see here the bag that contains the ram flap that we will later use for the perineal reconstruction. Now it's time to follow the plane in front of the prostate, and we have to take great care not to come too close to the tumor, and therefore on the patient's right side, in this case, we have to sacrifice the neurovascular bundle, as you will see later. On the left side, we are trying to save the neurovascular bundle, and you can see here a small clip that we put up from the abdominal side in the inferior hypogastric plexus. You can see the neurovascular bundle close to the left vesicle. And here you can see the clip that we did put on the inferior hypogastric plexus from the abdominal side of the operation. This is convenient because we can then follow the neurovascular bundle along the vesicle and the prostate. And the only possibility to save the patient's sexual function is, of course, to identify the nerves and to save them. And the only way to do that is that you actually can see the nerves. So we try to dissect the nerve and the neurovascular bundle from the specimen, and it's good to use a scissor here, because if you use too much diathermy, you may harm the nerves. We work gradually distally, and you can here see the vesicle, the neurovascular bundle, and we try to ease the neurovascular bundle from the specimen. Once you have entered the correct plane between the adenovillous fascia and the prostate, it's quite easy to follow along the prostate and to divide the final part of the levator muscle. And again, we have to take great care not to damage the nerve on the patient's left side. There are small branches of vessels that you can easily control with diathermy. And now you can see how we ease off the nerve from the specimen, trying to preserve the nerve all the way along the prostate. This is a difficult area because there are small vessels and it's very easy to get into the prostate and have bleedings. Again, here you can see the neurovascular bundle. On the patient's right side, the tumor is close, and therefore we have to sacrifice the neurovascular bundle on the right side. And you can see here that we divide the bundle with diathermy to be absolutely sure not to come too close to the tumor. This is, of course, a procedure where they may have bleedings from the neurovascular bundles, and you have to stop those. Once you have passed this area, you are onto the prostate, and then you just follow the back of the prostate along the adenovillous fascia all the way down to the pelvic floor. There are always some bleeders that you have to control with diathermy. And it's also important to have a Foley catheter in the urethra so that you are absolutely sure not to damage the urethra within the prostate. Once you have passed the plane of the prostate, you just divide the final strands of muscle and the pelvic floor and the perineal body. And when you have done this, the specimen can be extracted. In this particular place, there is really no anatomical plane because the muscles are fused together into the perineal body, and you have to divide that sharply before you can excise the specimen. Here you see the specimen. We have a very nice surface, good TME, and as you can see, this is a cylindrical specimen with the levators attached. This is the patient's left side. We have also taken a piece of the sacrum here. You can see that we have the valdeus fascia there, and on the patient's right side, the tumor was very close to the levator muscle, and therefore we took more tissue on this side. But as you can see, we have a very good covering of the tumor, and it looks, at least macroscopically, as if this is a radical R-naught resection. Once you have extracted the specimen, you can look at the anatomy of the pelvis. And here you can see the neurovascular bundle, the vesicles, and the prostate. And you can also see on that side the obturator muscle that we have mobilized completely or freed completely. And we have divided the neurovascular bundle on the right side, but not on the patient's left side. Small bleeders in the prostate are best controlled with small stitches. And then we should rinse the operative field with sterile water. Now we have taken down the ram flap that we will use to cover the perineal defect. In this case, we have a huge perineal defect, and a primary closure may cause infection, so therefore we have used a flap to cover this defect.